Good afternoon, and welcome to our quarterly webcast of the Methodist DeBakey Cardiovascular Journal. I'm Miguel Quinones, the editor-in-chief of the journal, and the current issue of the journal is dedicated to the topic of structural heart interventions. And we selected that topic because there's just been an awesome amount of progress in that field, and the amount of interventions and fixing that can be done with catheters now, particularly in valvular heart disease, but even also in congenital heart disease, vascular and so on, it's so amazing that, and so much has happened in the last few years, that we thought it would be a good idea to put an issue dedicated to that particular topic. And I'm greatly indebted to Dr. Goel, who is one of our senior interventionalists here at Methodist, and he's the director of the Structural Interventional Program at Methodist. And he was kind enough to accept the job of being the editor-in-chief for this particular issue. And Sakin, I really owe you on that one, because it is a mission of love. And he's put together a wonderful list of topics and with great authors. So what we want to do today is we want to go through some of those topics. We may not be able to cover them all. We have some of the authors joining us today. And it is going to be more of an interaction, dialogue, and I hope that you all can learn some of the new things that are happening in this particular field. So without any further delay, I will bring Dr. Goel to take over and join us and bring the rest of the participants in.
Well, thank you very much, Dr. Q, for inviting me to edit this issue. This is a very special issue and very close to my heart. And it was truly an honor, and I truly enjoyed the process. First of all, I would like to thank all the authors who participated and put in their time and effort in making this issue such an enjoyable one. In addition, I'd like to thank the team at Methodist DeBakey Cardiovascular Journal, who did a fantastic job keeping us on track and producing such a remarkable issue. So today with us, we have Dr. Michael Reardon, who needs no introduction. Yeah. Dr. Reardon is our senior cardiac surgeon, the surgical director of the structural intervention program here at Houston Methodist. He's the Ellison Family Distinguished Chair of Cardiovascular Research, professor of cardiovascular surgery at Methodist DeBakey Heart and Vascular Center. Welcome, Dr. Reardon, and thank you. In addition, we have Dr. Colin Barker, who is the Director of Interventional Cardiology at Vanderbilt Heart and Vascular Institute in Nashville, Tennessee. Welcome, Dr. Barker.
Thank you for having me.
And our third participant today is Dr. Samir Kapadia, who is running a little bit behind and is stuck in another commitment. Dr. Kapadia is Professor of Medicine at Cleveland Clinic, Lerner College of Medicine of the Case Western Reserve University. He's the chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Seidel and Arnold Miller Family Heart and Vascular Institute in Cleveland. He will be joining us shortly. So I would like to go ahead and discuss the first couple of topics which are related to transcatheter aortic valve replacement. And none other than Dr. Michael Reardon, who's been really a pioneer in this field, leading the field from the origin of TAVR to the new generation TAVR valves and the newer technology. So the first review is what's new with TAVR and update on device technology. So Dr. Reardon, could you tell us what is new with the latest generation of the SAPIEN and the Evolute transcatheter valves that we've been using for such a long time?
Well, thank you, Sachin. Well, as you know, these valves continue to iterate at lightning speed. And what we've seen over the 20 years these valves have been around, I've never seen in the 40 years I've been practicing. So the original balloon expandable, SAPIEN has gone from SAPIEN to SAPIEN XT to SAPIEN 3 to SAPIEN 3 Ultra, and now there's going to be an X4 valve coming out. It's still original cobalt chromium frame, which is balloon expanded. It's still a pericardial valve, but they now use a new tissue technology, Resilia, which allows you to store this valve dry. And the new X4 will come already mounted on a balloon, so it's getting easier and easier. You don't even have to mount your own valve anymore. You just pull it out, you don't have to prepare it, and you just go right in. One of the things that we're all very interested in is being able to achieve commissural alignment like I do at surgery, so the commissures line up and the coronaries are between the commissural posts. That's been hard up till now. The X4 is going to have a way of rotating and lining up the post, but now that is just in trials right now, and it'll be a while before that's actually out. So right now the balloon expandable valve is very hard to line up, but certainly very easy to put in. The self-expanding supraannular valve, which is the Evolute family of valves, has gone from core valve to Evolute R, which was recapturable, to Evolute Pro, which had a skirt on it to help decrease paravalvular leak, to the newest one, which is Evolute FX. And what Evolute FX has done is a couple things. One, its delivery system used to have two spines that went down the delivery catheter, and that made it a little unyieldy. So they've taken it down to one spine, which makes it track a lot better, and it's easier to get into things such as horizontal aortas. The delivery is now such that it moves a lot less than the original ones did, and it has 3 dots on it, which allows us to very easily line up and get commissural alignment 90% of the time. And if we're thinking to the future, where we might have to put another valve inside here, of course we don't want a post in front of the coronaries. The next generation will be called the FX Plus, and what it'll have is, instead of a 12 French opening in front of the coronaries, it'll have a 20 French opening in front of the coronaries to make coronary access easier. So both the original balloon expanded valve and the nitinol frame self-expanding Evolute valve have undergone some real changes that have made it easier to implant, more reliable to implant, and has given us less paravalvular leak and less pacemaker. So we're really moving forward with those 2 valves.
Thank you very much for that nice overview of the SAPIEN and the Evolute valves. So that's a nice segue for us, perhaps, Dr. Reardon, and our audience to learn a little bit about the new transcatheter valves that are ongoing clinical evaluation and trials, such as the Portico Navitor and the Accurate Neo 2. Could you speak a little bit about these 2 valves and what's your experience?
Sure. So as you know, Sachin, the balloon expandable SAPIEN family and the self-expanding Evolute family have now been randomized in all risk levels and approved at all risk levels in the U.S., which has led to our current guidelines that say if you're 65 or less, or going to live 20 years or more, you should still consider surgery. 80 years or older, or going to live 10 years or less, and you're a good candidate for transfemoral TAVR. TAVR in between 65 and 80, physiologic risk of surgery, anatomic risk of TAVR in patients' decisions. So those have been approved. Now the Navitor valve, which is originally the original Portico valve, has been approved for high and extreme risk. And then the new version of that was called Portico NG, which has now been renamed Navitor. I ran that trial with Lars Sondergaard. That trial is complete, and that valve is now approved and available on the shelf. The next study for the Navitor family of valves will be the Vantage study, and I happen to be the international chair with Azim Latib on that trial, and it will look at low and intermediate risk. Now, it's already ongoing in Europe and Australia, where it's a single-arm study. In the U.S., it's going to be randomized against commercially available valves in a 2-to-1 randomization. So we expect to start that this year, so it'll come forward. The other valve is the Accurate valve, the Accurate Neo 2 now. That was an interesting trial because it was the first and only trial that was using all risk levels, extreme, high, intermediate, and low, randomized against the commercially available valve, which was the S3 or the Evolute. That was a 1,500 patient trial. I was fortunate to run that with Raj Makar from Cedars. We've completed that trial. We will have our 1-year data coming out in about a little less than a year, and we'll be able to bring that data for you. We've also seen a couple valves for aortic insufficiency. The Jena valve, which was in the Align trial for aortic insufficiency, you and I participated in that. I'm fortunate enough to sit on the executive committee of that trial. We've completed that trial, and so we hopefully will have a valve specifically designed for aortic insufficiency. And the J valve, which is another valve designed for aortic insufficiency, we participated in an early version of the EFS that got stopped to allow for financing. It's now being restarted. I'm going to have the opportunity to run that with Dean Kariakis from Christ Hospital, and we've submitted our protocol to the FDA, and we should start an EFS soon. So there's some really exciting things going on with new developments in TAVR valves.
So if I can summarize a little bit of what I've heard, since I'm somebody who only sends you the patients, I'm not in the cath lab doing it.
Yeah.
If I can summarize what you were saying, we have a whole new generation of valves coming in for aortic stenosis, with the hope that each model that comes in will A, make it easier to implant, B, reduce AR, paravalvular leaks, which is a big deal. But the long terms, of course, are unknown because they have to be followed. So, two questions. One is, are you hopeful that the whole issue of paravalvular leak will eventually become history? That's my first question.
Yeah, I think so. So right now, if you look at the valves that Dr. Goel and I use on a daily basis, which are the S3 valve and the Evolut FX valve, and you look across national data, there's almost no moderate or greater paravalvular leak. That's almost unheard of.
Great.
And right now we have about 20% mild and 80% none to trace. Now the problem, of course, is as we move to younger people, even mild is something we need to eliminate. So our goal right now is to see mild at less than 10%. You know, if you're 84, mild's not probably going to hurt you, but if you're 65 or at the lower end of our guidelines and you live 20, 25 years, then mild AI over that period of time might make a difference.
And I can testify that at least in our hospital, what he's saying about reduction of moderate AR to very little is true, because in the echo lab we're seeing them every day. And it's true. We see very little of that moderate AR. Now, my other question is, you're a practicing cardiologist. Once these valves hit the market, how in the heck, as a practicing cardiologist who doesn't have the privilege that we have here of being exposed to all these wonderful new developments, how does a regular practicing interventional cardiology chooses a valve?
So I think most sites, we fortunately have a big enough site that we can use multiple valves. But most sites are probably out there doing 40 or 50 TAVRs a year at most. And they should really have a workhorse valve, but most sites really should have both a balloon expandable and one of the self-expanding valves as they come out. And the reason they should is that the hemodynamics from the self-expanding valves are all much better than the balloon expandable valves. And as you move to smaller and smaller annulus, it becomes more and more important for hemodynamics. And if you're going to do a TAVR valve inside a failed surgical valve, and that failed surgical valve is a 23 or less, we have very good data that with a balloon expandable valve, you're much more likely to have a residual gradient, a mean of greater than 20. And so most sites really should at least have access to both, know how to use both. But if you're doing 40 or 50 a year, you're probably going to have one workhorse valve.
And to me, one thing that always, if you're practicing cardiologist, is it better to use a valve that has been at least now 7, 8, or 9 years, so the long term is known, or pick up the newest one because his sales guy took you to dinner? I mean, I'm joking a little bit, but there is that tendency, the sexy tendency of just pick up the newest one because supposedly that's the one that has A, B, C, D new results.
Well, so the newer ones, we have ways of comparing them against the ones we have right now. Now, there's only 2 valves that have been compared randomized against surgery. That's the balloon expandable Sapien family and the self-expanding Evolut family. The longest data is actually from the Notion trial, which is the Nordic countries, Norway, Finland, Sweden, and Belgium. And they actually very early on, starting in 2009, put together a superiority study looking at people 70 or over that were lower intermediate risk and randomized them against surgery. The 8-year data has been published, and the mortality is the same right on top for 8 years, and the hemodynamics are better for the self-expanding, but good. The last patient passed the 10-year mark in April this year. We're going to get some 10-year data coming up pretty soon. And once we get to 10 years, particularly in this group that were just 70 or older, where we actually have a fair number of people surviving, that's going to be helpful. Remember, in the randomized high-risk trial in the U.S., the mean age was 84, and the intermediate risk was 81. Low risk at 73 and a half. We really have to get down into the mid to low 70s if we're going to have survivors and make a real
thing. Which takes us to the next question, right, that we had for Dr. Reed.
Yeah, so this is a perfect segue into the next topic, which is the durability and long-term outcomes. I know, Dr. Reardon, you just alluded briefly to the long-term outcomes, and Nordic the Notion trial is probably the study which has the longest published follow-up. But can you tell us a little bit and the audience about THV or transcatheter heart valve degeneration, and how does it occur, and how does it compare with surgical valves? What have we learned?
So I think it's very important for people that read the literature and think about this to understand the difference in the way surgeons have traditionally looked at this and the way we're looking at it now that we have transcatheter valves. Surgeons have traditionally looked at it as I put a valve in you, and unless you come back and get another valve, you're a success. Now the problem is many of these people would never come back for a second operation. They've had enough. And so we underestimated the rate of degeneration, number one. Number two, valve degeneration is not an on-off. It is a gradual process, just like aortic stenosis. So one of the things we've done from the VARC-3, which data where we're trying to standardize how we look at this, is define moderate structural valve deterioration and more than moderate structural valve deterioration. And moderate is described as an increased mean gradient of 10 millimeters mercury or more from your discharge or 30-day echo to your current echo with a final mean gradient of 20 or more. Severe is an increase of 20 or more and a final of 30 or more. Now, if you look at that, they do have some pretty good data on that. So the Partner 2A, which was the intermediate risk trial, which randomized against the XT, which is an older version of the valve, versus surgery, XT had over 9% structural valve deterioration, surgery had 3.5, so statistically more in the XT. We don't use that version anymore. They had a non-randomized continued access with S3, and they propensity matched, and it was 3.9 for the S3 valve, 3.5 for surgery, statistically no different. Now I must say, if you look at the footnotes in the paper and in the supplement, if you do weighted treatment propensity matching, which cuts off the tails, S3 actually lost in years 4 and 5. Now we got interested in the same thing for the self-expanding Evolut core valve, and I presented this at ACC, I think 2 years ago now, and we looked at the randomized arm from the high risk and the intermediate risk to look at the difference in occurrence of structural valve deterioration. That's over 2,000 patients. And at 5 years, it was 4.3 for surgery and 2.3 for TAVR. So this is really kind of the first time we've shown that there's statistically less moderate or greater structural valve deterioration for TAVR than surgery. And then we went and looked at it, and we added in the continued access, which got us to over 4,700 patients, to look at what was associated with getting it and what were the clinical outcomes. And the clinical outcomes, if you got moderate or greater structural valve deterioration, whether you had TAVR or surgery, it doubled your risk of all-cause mortality, it doubled your risk of cardiovascular mortality, it doubled your risk of being rehospitalized for heart failure or an aortic valve reintervention. So that's pretty impressive data at 5 years. The intermediate risk trials and the low risk trials, randomized trials, are going to be followed out 10 years. We've always known that TAVR had an early advantage. The question is, would that advantage hold up? We recently published the 3-year outcomes for the low risk Evolut trial, and when we saw at 30 days for a primary endpoint of all-cause mortality or disabling stroke, TAVR had an advantage of 1.8%. 1 year, 1.8%. 2 years, 2% in favor of TAVR. 3 years, 2.9%. So this is the first trial where we actually see it widening out, whereas in the Partner 2 data, that primary endpoint of all-cause mortality or disabling stroke crossed at 3 years, where TAVR then got, not numerically, but not statistically worse than surgery. So we really have some very exciting durability data. Now remember, in the surgical world, different surgical valves degenerate in different rates. It's not a class effect. Different TAVR valves would degenerate at a different rate. Durability is a combination of valve design and tissue science. So I think we're really starting to generate, I think, the data that we need. It's going to take about 5 more years, Michael, but I think once we get 5 years out, we'll really have some good data.
So there are the statistics, which you have shown beautifully, and then there are the individual anecdotes.
Yeah.
So I'm always puzzled by that. So we have this very nice 78-year-old fellow who got the TAVR and was happy, and then 3 years later he comes in and what the heck happened? The gradient now is much higher. So you have those individual situations. Yeah. Do we know anything about them, about the pathophysiology of that? Is it just bad luck? Is it a clot that got in there? Is it just, do we have any knowledge about those individual situations where they tend to progress a lot faster than the rest of the group?
So most of these are HALT, or hypoattenuation leaflet thickening. And once it gets to be about 50% or more, you usually start to see an increased gradient in clinical things. But you can actually pick it up before then if you do either a TEE or a 4D CT. You can't generally see it on a transthoracic.
Right.
If you put these people on oral anticoagulation, Coumadin or one of the NOACs, it'll go away. We don't know how long it will stay, how long you have to keep on before it goes away. Now, some of those go on to permanent, and they don't get better. But we've looked at these. These are early valve thrombosis. And it's more common in pericardial valves than it is in porcine valves because bovine pericardium is thicker than porcine pericardium. And all the valves are bovine except for evolute, which happens to be porcine. All surgical valves are bovine.
Very interesting.
And it occurs in surgical valves too.
So a question for you, Dr. Aaron. You are in the clinic, you're seeing TAVR patients referred for TAVR. You see a 68-year-old guy who comes to you and says, Doc, I want TAVR. So, how do you decide? And, what is this concept of lifetime management of aortic stenosis? Can you talk a little bit about this?
Sure. Well, I think the first thing you have to think about, Sachin, is that most cardiologists and cardiac surgeons interested in this know that there were 2 low-risk randomized trials that were positive for TAVR. Now remember, these are randomized trials, and randomized trials only apply to populations that are similar to the ones that were tested.
Yep.
So who didn't we test? We didn't test bicuspid valve. We didn't test any significant coronary disease. We didn't test anybody that needed a additional procedure besides coronary bypass. So no ascending angiogram, no mitral valve repair. And we didn't test anybody that was appropriate for a mechanical valve. And one of the exclusions of both trials was excessive LVOT calcium, which is hard to define. So those people, you've excluded half the people out there already. Now, number 2, in both these trials, they were seen by a local heart team of experts who said they have the inclusion criteria, no exclusion criteria, and we say that the anatomy is good for either surgery or the TAVR valve we've chosen. One would think when we went to a national screening committee, everybody would be accepted. In the Partner 3 lowest trial, 34% of people were rejected at the national level.
Wow.
And Evolute, 14.8% were rejected. So again, these are not all comers. As you know, we can treat many bicuspid valves, but it depends on the anatomy of the valve. So what I do with that 68-year-old is I'll sit down and I'll look, and most importantly, not only how they're doing physiology, but the anatomy of what we see. If they are a tricuspid valve and they are slam dunk, transfemoral case, I'm fine doing a TAVR, and talking to them about it. If they're not, then I start talking to them about surgery. Another thing that you have to point out to folks is a lot of people think if I get my TAVR and it fails, well, then you can just take it out and operate then. The data says that the hazard risk of death is 2 to 3 times greater than just getting an aortic valve done, a surgical aortic valve, because of the complexity of taking these things out. So it is a very nuanced conversation. But, everybody comes in looking for TAVR. There are very few people come in and say, hey, doc, would you crack my chest open?
Absolutely. Well, I think this has been a wonderful conversation about TAVR and the advances in TAVR. Good discussion on on TAVR durability. Thank you very much for this, Dr. Reardon. So moving on, I think Dr. Samir Kapadia has just joined. Thank you, Dr. Kapadia, and welcome to the webcast. Dr. Kapadia is the Professor of Medicine and Chief of Cardiovascular Medicine at Cleveland Clinic. Can you hear me, Dr. Kapadia? So Dr. Kapadia and colleagues have contributed a excellent review on transcatheter edge-to-edge repair for the mitral valve or MitraClip. And this is a truly amazing review article where they discuss anatomic characteristics that are feasible for TEER, how patients are selected, the role of imaging, and they share the pertinent data on primary and secondary mitral regurgitation and treatment with TEER. Dr. Kapadia, are you able to hear us?
Yeah, I'm here too. I just made it.
Thank you very much for joining. I know you're super busy and running around. So if you're ready, we can ask you a few questions.
Sure.
So in your practice, in your mind, what are the ideal anatomical characteristics for successful mitral transcatheter edge-to-edge repair?
So the most important thing is that if you can put the valve anatomy together such that both leaflets coapt and you are able to create the coaptation line that is not distorted without compromising the orifice of the mitral valve, then that is the most important characteristics in my mind to say that how we will repair the mitral valve by edge-to-edge repair where the anatomy will be restored. And if this is possible, then these are the right patients for edge-to-edge repair.
Yes, completely agree. And then, along the same lines, what constitutes suboptimal anatomy in your mind, and what constitutes prohibitive anatomy? Meaning, when would you not offer TEER based upon the, purely on anatomical basis?
So the most important part is, so let's say the flails, so if you have a primary or secondary MR, right? So in the primary MR, if you have a flail segment that is very large, or if the flail segment is such that there is no opposing coaptation leaflet that is big enough. So let's say there is a large anterior flail and the posterior leaflet is small, or if the annulus is very enlarged in the primary MR, where you think that even though you can repair some of the leaflet, you will still have large prolapsing segments like in Barlow's valve, then you would not do such primary MR treatment. On the other hand, let us say that if you have a functional MR, then if the valves are very, very seriously restricted, then that would be a problem. If you have a valve that does not open fully, in the sense that if it's apically tethered, then sometimes the valves will not open completely. And if you put a TEER edge-to-edge repair, you will have mitral stenosis. Or you have MAC such that your valve is restricted, then you will have mitral stenosis. So all of these areas, you would at least consider the TMVR therapy, where you would replace the mitral valve rather than repair the mitral valve. If the annulus is very enlarged, like in atrial AMR, then also you may want to consider something that would cause reduction in the annular size. So these are the things that come in mind when you are evaluating the anatomy.
Thank you. So when you see these patients, the Heart Valve Collaboratory has come up with this classification of green zone patients, the red zone, green zone meaning suitable for TEER, red zone is not suitable or prohibitive for TEER, and then there is a broad yellow zone or gray zone, as they call it, suboptimal for TEER. When you see these patients in your practice, what is your algorithm? Do you do you get a CT? Do you evaluate them for TMVR and see if they will qualify for a TMVR device, or do you individualize this on a case-by-case basis? How do you tackle this situation?
Yeah, very good question. So these days we are doing three things. So first of all, a heart failure doctor, a interventionalist, and most commonly a surgeon sees the patient. So the three people are seeing instead of two in the TAVR population. And then we are doing most of the time a transthoracic echo first to determine that whether we need a TEE plus CT scan or just a TEE. Many times, if the creatinine is normal, we prefer to do a CT scan in all the patients. So that way we can evaluate the anatomy, not just by the echocardiography, but also by the CT. What this does to us is to provide us the options of either doing TMVR or TEER, or we are also involved in the annular reduction therapies. So either of these three therapies, we would then try to understand that which would be the best method to treat the mitral regurgitation. And again, surgery in the past used to be our way of thinking that, okay, if we send a patient to surgery, this is what we would do. This is not how we are thinking these days. We are saying that how we would treat them percutaneously and what are the therapies. So we are not using surgery as a gold standard to say that we want to mimic what we would have done in surgery, because we have learned that the TEER works without annuloplasty ring in functional MR. So there is no reason to use surgery as a mechanism to say that whether we should do something which would have done in surgery. So this is the way we are thinking these days to evaluate the patients.
Excellent, thank you. One final question. With the edge-to-edge repair, do you find the Pascal device, which was recently approved for primary MR, do you find that beneficial in certain anatomies? And if so, which ones would you prefer using a Pascal device over the MitraClip?
So both the devices have their characteristics and the ability to treat different patients. So Pascal obviously is better for smaller valves because it has a little spacer, so the gradients will be less. Other than that, other advantage of Pascal is that you can easily move the device without getting tangled in the subvalvular space. So if you are going to have a situation where you want to manipulate the device in different locations to see which one would be the right location, then it is a little more forgiving. The downside of this device is that we would have to have a device that is, if you want to cinch the valve, bring it very close together, the anterior and the posterior leaflet, sometimes it is difficult to accomplish that with the Pascal device because it has a spacer in it. So this is the main reason which device you will choose, one over the other. And also, Pascal has a smaller ACE device that can go in the commissures, but if you are going to go in the commissures, again, the clip may be slightly easier, especially the smaller clips. So again, we are learning. So we will decide how we decide one device versus the other in the future.
Excellent. Thank you very much. Dr. Q, do you have any questions for Dr. Kapadia for edge-to-edge repair?
No, not at this time.
Yeah.
Thank you very much. Thank you so much, Dr. Kapadia, for joining you. Good to see you.
Thank you.
Good. Pleasure. Bye-bye.
Thanks again for your time and contribution. Excellent. So thank you.
So you know.
Dr. Q, you want to take us through the next
Yes.
subject,
Well,
TMVR?
it's actually my pleasure to ask some questions to Dr. Barker since
How do you go to Dr.
some
Goel?
years back we were colleagues. In fact, I still remember a couple of difficult patients we managed together.
I think you're going to Goel right now.
Oh, no, I'm sorry. It's to you. Yeah, my mistake.
Yeah,
I'm supposed
so
to be
my
asking
TMVR,
you some
and
questions.
then we'll.
Yes, because you also were the author of a very important paper on catheter mitral valve replacement with dedicated devices. So this is a new field. And I guess the first question is, what's the ideal patient for this? I'm assuming over the years that answer is going to change as we learn more and get more devices. But currently, what do you consider the ideal patient for TMVR?
Yes, absolutely, Dr. Q. So this field is rapidly evolving, and as Dr. Kapadia also briefly alluded to, patients who are suboptimal candidates for edge-to-edge repair with MitraClip or Pascal device for that matter, or certainly that are prohibitive anatomical candidates for edge-to-edge repair are ripe for consideration for TMVR. What we are learning is TMVR is very effective therapy, meaning it completely abolishes or eradicates mitral regurgitation in contrast to edge-to-edge repair in some of these challenging anatomies where we may not achieve a desirable result. A desirable result is a reduction in MR from severe range to mild or less. We've learned that anything more than mild residual MR is associated with poor outcomes in treatment of MR. So TMVR is a good option as long as it is anatomically feasible, of course, for patients that are suboptimal or poor candidates for edge-to-edge repair. Of course, these patients are also high surgical risk. Otherwise, they would be repaired surgically.
Yeah, actually, I was going to ask you that. So the first step in the whole thing is declaring them high risk for surgery, I would imagine.
That's right.
Yeah,
That's
good.
right. These are all high surgical risk patients.
Yeah. Now, we are privileged to have you with us, and we're in a center where we're doing a lot of these things. But still, these cases don't grow on trees. I mean, we're still kind of doing a few cases here, a few cases there. So it appears that overall, the field still moves relatively slowly. And I'm assuming that this is because there are challenges. So can you give us a few,
absolutely.
What are the kind of the main challenges that are making us have to scratch our head in selecting patients?
Yes, that is absolutely true. I think you hit the nail here. This is not TAVR. The mitral valve is very different from the aortic valve. The aortic field, as Dr. Reardon succinctly gave us an overview, has evolved tremendously in a span of 1 decade, where we've gone from treating and approving TAVR for treatment of patients who are high, intermediate, and low surgical risk. The mitral valve obviously is a different ballgame for multiple reasons. First of all, the anatomy is far more complex. It includes the mitral leaflets, the chordae tendineae, the pap muscle, and of course, the underlying myocardium. The mitral annulus is a complex D-shaped structure, which is defined anteriorly, as you know, by the aortomitral curtain, which makes device sizing a challenging process. The Achilles heel, however, for TMVR has been the LVOT or neo-LVOT obstruction. When you put a TMVR device, the anterior leaflet of the mitral valve is going to cover the surface of the TMVR device, creating a neo-LVOT. And in many patients, this neo-LVOT can be dangerously small. And if LVOT obstruction occurs after TMVR, that is associated with more than 50% mortality. So this is one of the Achilles heel of this technology that needs to be sorted out. Secondly, the sizing. The mitral annulus is, as I said, a large structure, and often in secondary MR patients, the annulus is further enlarged. So some of the early generation devices have been restricted to 1 or 2 sizes. Of course, as we see continued innovation, this is going to grow and we'll see larger valves. But that is another reason why many patients get excluded. In addition, up until recently, a lot of these devices were delivered via transapical approach. And we've learned from the TAVR experience that transapical is associated with high risk, partly related to access issues, partly related to sicker patients. But now, thankfully, this is also moving into the transfemoral transseptal space, and the whole field is moving towards transfemoral transseptal implants. So, as a result of these anatomical reasons, the field has been somewhat slower compared to TAVR. But with continued innovation and newer devices and newer sizes, and importantly, transfemoral approach, we will see a growth in this technology going forward.
So, can you give us a brief idea of sort of what's cooking? In other words, these new devices, as the field progresses, what's the current stage of development?
So a lot of these, first of all, none of these dedicated devices are approved for commercial use in the United States.
Very important point to make, yes.
Yes, so I think that is very important to note. The most studied, perhaps, are the Tendyne system, which is by Abbott, and the Intrepid system, which is by Medtronic. These are probably the 2 most studied devices worldwide. The Tendyne does have CE mark in Europe, but not FDA approval yet. So the Tendyne briefly is a intraannular self-expanding nitronol bioprosthesis with a tri-leaflet porcine pericardial valve. It consists of an outer frame which serves as supraannular cuff to prevent paravalvular leak. This is only delivered transapically via a 36 French sheath and anchored to the left ventricular apex by an epicardial pad tether. And it is possible to tighten this tether up to a few days to weeks to reduce MR. The published cohort of 100 patients has been followed out to 2 years. The technical success, according to the WARC definitions, was achieved in 94% patients, and 1-year survival was about 72%, and majority were in NYHA class 1 and 2. The Summit trial is a trial which is looking at the randomized study looking at Tendyne TMVR versus TEER in patients with 3 plus or more MR. And there's also going to be a non-randomized arm, especially with MAC patients, that is going to evaluate the Tendyne valve. In terms of the Intrepid system, this is a 27 millimeter tri-leaflet bovine pericardial valve, which is surrounded by an internal frame as well as an outer fixation frame with a flexible atrial segment. It's available in 2 sizes, 42 and 48, with a new 54 millimeter valve, which is on the horizon. It is delivered via 35 and 37 French sheath via transapical or now transseptal and transfemoral approach. And the results from the pilot study and the most recently presented study at TVT are very encouraging, with high degree of technical success, lower rate of complications as we move the field forward. And we are all very excited to learn about the results with the transseptal transfemoral Intrepid device, in the Apollo trial, which is currently ongoing in this field?
That's very exciting progress. I think the take-home message for a clinician like myself is that TMVR is still to be done in specialized centers that are doing the research. It's still not ready for prime time in the average regular hospital. I think that's a good take-home message. Our next participant, which Dr. Goel is going to ask some questions in a minute, is Dr. Colin Barker, Director of Interventional Cardiology at Vanderbilt Heart and Vascular Institute. But Colin is an old friend. We worked together for a few years, took care of a very few sick patients. And one in particular, I remember, Colin, I don't know if you remember her yet, but this 85-year-old lady was in the CCU dying. She was in pulmonary edema, intubated, and hypotensive. And what she had was a hyperdynamic heart with severe SAM, and nothing that was done medically was getting her out of that. And on top of that, her septum was only like 1.1, 1.2 cms. So our alcohol interventionalist didn't want to touch her because there wasn't enough thickness there to put alcohol on. And of course, our surgical colleagues, as aggressive as they were, did not want to touch her. And Colin and I were talking about her. I don't know if you remember, Colin. We said, what about clipping that valve? Mm-hmm. And Colin said, sure, I can do that. So she went to the cath lab. She had the mitral valve clipped. The SAM disappeared. Within 24 hours, she started to get better. And a month later, she was shopping with her daughter. So it was one of the most spectacular cases I have seen as a clinician that truly has been saved by an interventional procedure. So my question to the two of you is what in the neighborhood of severe SAM has the edge-to-edge repair moving along? Is that an alternative to some of these hypertrophic obstructive cardiomyopathy patients, particularly if they don't have enough of a septal thickness to do the traditional septal ablation? Just throwing to you. Any opinions on that, Colin? Jump in. You were the one who saved this lady's life.
I remember well. Actually, she was the great aunt of one of our cath lab nurses too. It was a small world, but she was one of those cases that I do remember it well because the gradient was like 140 or 125. Yeah. But I think one of the interesting things, not to get off track here, but with HOCM in general is some of the medical therapies like mavacamten and using that in addition to, some sort of percutaneous intervention may have a role. The clip hasn't really taken off. I mean, I'd be interested in Sachin's thoughts as well, but it makes a lot of sense to pull the anterior mitral leaflet out of the LVOT during systole, but it's really been sort of only at this point saved for people who have no other option.
Yeah.
But it's very simple.
Yeah, I agree, Colin. That's where we've used it over the years. So, but that's very interesting anecdote. Thank you. So, Colin, switching gears to transcatheter tricuspid interventions, past, present, and future. So, first of all, I have a few questions. So, why do we need to think about transcatheter tricuspid valve interventions? Are diuretics not enough for these patients?
Diuretics help. They're not a cure. They do keep people out of the hospital with isolated severe TR, but they really don't change the natural history, quality of life metrics, et cetera, things that matter to people. So I would say they're a start when somebody initially gets diagnosed, but not by any means, a durable, meaningful treatment. And really, in order to do that, you need to fix the lesion, which is the leaky valve.
So tell us, Colin, when you see in your valve clinic a patient with severe tricuspid regurgitation who is symptomatic despite medical therapy, including diuretics, what is your sort of approach? What is your step-by-step approach, and how do you evaluate these patients for transcatheter therapy?
Sure, and they are a little bit of a complex group because of the heterogeneity of their symptoms and this just vast phenotype of players, but defining the lesion is pretty straightforward with a transthoracic echo. Looking for an etiology, is it a pacemaker lead? Is it a recent biopsy that got, the cords or the leaflet got clipped? Or is it what's probably most common is chronic AFib, with a dilated annulus and subsequent non-coaptation of the tricuspid leaflets. So we make, once you have the right diagnosis and the symptoms, which are different than left-sided lesions, weakness, fatigue, just not feeling well, even weight loss, lack of sleep. I mean, all these things you think you'd be maybe talking to a psychiatrist about, but it turns out it could be, tricuspid regurgitation. And then we want to figure out, okay, you have the disease, you have the symptoms, what can we do to get you feeling better? Obviously nothing available right now in the United States as far as FDA approved and CMS reimbursed, but sort of piggybacking on the earlier conversations, there's a lot of excitement and enthusiasm with transcatheter interventions with either a repair with an edge-to-edge device or a replacement. And we had both, which did bring some challenges to figuring out, which patient should we put in which trial, or which bucket. And then the default being, considering an off-label mitral clip. And in general, we were very enthusiastic about a replacement option if we could up front. Now, all these trials are very hard to, put people in because they were randomized to medical therapy with 2 years of a commitment, without having any intervention, as long as there's nothing else available out there commercially. So, but because the replacement group was, after they went through the screening process and similar issues with the mitral, a lot of anatomic limitations as far as feasibility of a replacement. And a repair with edge to edge really doesn't have a lot of limitations as long as you can image well during the procedure. So in addition to the usual clinical assessments, we do, in the case of tricuspids, want a TEE and really an idea of, are we going to be able to see what we're doing? Which, as you remember, when we all started doing this, that was a big challenge, but to the echocardiographer's credit, that's come a long way, where really that's less of an issue. And we can, I don't mean we, I don't do the echo, but the echocardiographers can come up with creative ways to manipulate their probe in order to get adequate visualization. So that's becoming less of a limitation, but initially is definitely part of the evaluation.
Yeah, I completely agree. In terms of as there's a lot of debate and discussion after the TriLuminate study was presented at ACC. What was your take from this trial and the primary endpoint and the lack of benefit with heart failure hospitalization and mortality? What do you make of all this, Colin?
I think we were all a little bit, well, let's be honest, we were disappointed. We were hoping for a home run, and it was barely a base hit. I mean, it was like a tie goes to the runner. When you look at the outcomes and what the differences were. So I was surprised. There were a lot of, and without getting into TriLuminate in too much detail, I think there were a lot of opportunities there from case selection, trial design and follow-up that may have changed it, but in the kind of glass half full, there are subsequent trials that are now, I think, being a little bit more, picky about who we pick and who we treat. Because it was interesting, with the difference, the only thing that really was different, just by a little bit, there's a lot of discussion about how this trial could have essentially been entirely neutral with one or two patients going the other direction, was the KCCQ, based on a strategy of statistics that was a little confusing with the win ratio. But that did not translate into something more objective, like a 6-minute walk test, which you would expect. So I think it was good that it didn't fall on its face. I think we were expecting more, but I think it also increased the enthusiasm to try to improve more and innovate on what we can do for these people.
Absolutely. I think is going to keep the field live and kicking, and we'll see more trials and perhaps more edge-to-edge repair and other technologies, and TTVR or transcatheter tricuspid valve replacement, which brings the final question for you, Colin. Who do you think may be more appropriate candidates for TTVR? With TEER, we still have some residual mitral or tricuspid regurgitation. So we learned from MR that even anything more than mild residual MR is associated with poor outcome. Could the same be the case with tricuspid? Should we be considering TTVR so we can eliminate TR? What are your thoughts?
Yeah, and that's exactly what we're all thinking, right? Like, how are we going to sort this out, or come up with some algorithms or sort of treatment pathways? And and we're learning a lot because of frankly neglect of tricuspid regurgitation. The natural history wasn't as well defined for untreated TR until recently, and we actually were part of one of these large database studies, looking at sort of payer data, and the mortality of isolated TR is 4% per year. So we're not talking about something coronary disease, aortic stenosis, something like that. But these people across the board feel terrible, and if you can improve how they feel and their quality of life with any therapy, that's a win. I think after going back and forth, my preference, and it's entirely my own opinion, will be to start with edge-to-edge repair. I think we've treated someone recently with a 3 centimeter squared ERO, so not 0.4, 3 centimeters squared, and got it down to 1.2. I mean, you could split hairs. That's still severe TR. And that was 9 clips, 1 SLD, but 8 clips. Wow. And that lady was not as sick as the one Q and I took care of, but she was sort of refractory, not advanced heart failure candidate. And really the problem was her TR that had gotten missed for years. She'd been seeing pulmonologists, et cetera. And it's only been a little over a month, but she's a different person. And the other thing we've learned, we can do TTVR in someone who's had a TEER. It doesn't take that off the table if it fails. There's plenty of room. The technology is being designed in such a way that shouldn't interfere with it. So my personal bias would be to lean towards TEER, which is very safe, can be effective, and really doesn't eliminate a whole lot later, as opposed to in mitral, it gets a little bit hairier. So I think that's what I would sort of propose and encourage people to think about.
Absolutely. Well, that must be a record, Colin, 9 clips. That's pretty amazing.
You should see the chest X-ray.
So Colin, tell me what you think about some really unique things such as a trick valve, just putting a valve in the inferior vena cava right atrial junction and the SVC right atrial junction, just ventricularizing the right atrium. We've done a couple of those and been surprised at how well they've done when we got the back pressure off the kidneys and they could really diurese.
Yeah, I think that's exciting, and as you guys know, it's very easy, right? It's not a hard procedure, and it works for just what you mentioned. And now, will that translate, into other, meaningful outcomes to, patients, et cetera? I don't know. I've been skeptical, about heterotopic or heterotopic valves, but it definitely, I think, will have a role, because there's some of these just end stage people that let's switch our thinking more to like an oncologist, where the length of life may not be that long, but if we can do something over a short period of time to improve the quality of life, I think that things like that trick valve will definitely have a role. And in failed people who've already had clips and valve replacements with recurrent TR, and there's nothing else to do, you have the trick valve in your portfolio. These are the most unhappy people I think that Sachin and I see in our clinic is people with severe TR. They are truly miserable. It doesn't kill you, it just makes you wish you were dead. Mm-hmm.
So we can also say that that all these catheter interventions in the tricuspid valve, likewise, are still in a development phase and better done by specialized centers, not the average interventional cardiologist. So the average clinician in practice still has as an option with this patient either continue medical therapy or send them to a surgeon for repair/replacement. And without divulging Dr. Reardon's age, I'm sure that you have in your career seen a lot of tricuspid valve and done some repairs and some replacement. So as a surgeon that is actually looking at the valve, what do you use as criteria for, I need to replace this one versus I can get away with a repair?
You can almost always repair them. I mean, the last tricuspid repair I did was yesterday on a lady that had a previous mitral repair that had become stenotic and needed a mitral valve replacement and had bad TR. And if you're doing a mitral and a tricuspid, it actually decreases your mortality. But if you're doing an isolated tricuspid, the mortality tends to be very high, not because the operation's hard, because somebody's waited so long they have a burnt out right ventricle. Mm. So we almost always, unless it's endocarditis or one of the kind of inflammatory diseases of the valve, you can always repair. Generally they have an annulus that's beyond 4 centimeters. If you bring the annulus down with a band, they almost always get better.
Which brings us perhaps to the last question, since we are almost out of time. Colin, give us a 1-minute summary on what's happening with this annular reduction type of therapies. Is that going to go anywhere? Dr. Capara,
the Carilion.
mentioned that they were involved with that too.
Yeah. I think if it could be as good as a surgical repair and a band like Mike does, it would. The issue has been durability, with stability of anchoring mechanisms, coupled with the anatomy in the neighborhood, right coronary artery being one of the more important things. So I think there's still enthusiasm there, but before that ever gets to prime time, there will be edge-to-edge repair and replacement, I think, pretty widely available.
Yeah, there'll be better techniques than the Carilion or the ones that have little anchors, but it takes you 4 hours to do one. Nobody's going to spend that much time.
I think for any transcatheter therapy to be successful and widely adopted, they have to be, first of all, safe, they have to be effective, and they have to be simple.
Yeah.
I think these are the 3 main components that makes any of these things successful and widely applicable. Otherwise, they're going to be reduced to just a few centers.
Well, Sachin, I just wish I could live 20 more years to see what you and Colin and your generation are going to bring forth, because it is really exciting to see what's happened in the last 20 years.
I totally second that. And with that, the hour is gone very quickly. We've had some absolutely wonderful teaching points and comments, so I really want to thank all of you for participating. And we wish all of our audience a good evening and a happy night and a good dinner, and drive carefully.
Thank you.